All right, guys. So let's finish up with the second half of the atrial rhythm lecture. Now, one of the things I want to stress to you is please, 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 please watch this video. Watch it as many times as you need to because I don't want you to get behind. But again, I don't want to move faster than what you would normally do. So, again, as we're always doing, okay, let's go through the review of the electrical conduction system. So, under normal circumstances, it starts here in the SA node, comes over to the left atrium, and then finishes up into the right atrium by way of Bachman's bundle and the internodal pathways. The next thing that happens is it stops at the AV node, then it breaks down here into the bundle of His, this area right in here, and then it splits out into the left and right bundle branches, and then it spreads up into the ventricles by way of the Purkinje fibers. Just as a way of review, keep in mind that when the SA node stops and it fails to fire, another impulse will take over. Now, we covered that. We talked about wandering atrial pacemaker. We talked about multifocal atrial tachycardia, and we talked about premature atrial contractions. Key thing to remember with premature atrial contractions is that you're always going to have to identify that underlying rhythm. So again, if I ask you this on a quiz, I ask you this on an exam, and you only identify the PAC, you're only going to get half credit. So with PACs, as well as some other rhythms that we'll get into later in the semester, if you don't identify the underlying rhythm, you only get half credit. So as we're going on in through here, again, the thing that we're looking at is the next one is called paroxysmal supraventricular tachycardia. Let's break that down. So paroxysmal means a sudden start and or a sudden stop. Okay, paroxysmal, sudden start and or sudden stop. Supraventricular means it's happening above. Supra means above. So it's happening above the ventricles, which the only part of the heart that's above the ventricles is the atria. And tachycardia is going to be a rapid heart rate. Now, the correct identification for paroxysmal supraventricular tachycardia is you just want to call it PSVT. That's perfectly okay. In essence, what we see here is that the atria can override the SA node and begins to fire really fast. Now, we talked in class about sinus tachycardia being any heart rate that is above 100, as long as everything else is coming from the SA node. With PSVT, it is going to be firing from someplace in the atria, and it is actually going to be faster than 130 beats a minute. Now, that's going to be a key thing for you to remember of when you are looking at these rhythms. If the rate is faster than 130, meaning 131 or higher, then what's going to happen is that this is no longer going to be a sinus tachycardia. It's going to be some type of a supraventricular tachycardia. And if you can see it suddenly stop and or stop, then we call it as paroxysmal or PSVT. Now, the key thing to remember here is PSVT is generally not associated with heart disease. Most of the time, PSVT is actually going to happen in people of your age, and the most common causes are going to be either over ingestion of caffeine or an increase in the amount of stress that a person is undergoing. Now, one of the things I like to tell students is that Madison County EMS will typically get really busy the week prior to and the week of finals because two things happen. Number one, finals stress everybody out. I'm going to let you in on a little secret. Finals will stress your faculty out almost as much as it will stress you. Now, I know you'll find that hard to believe, but it really does. The other thing that happens is that both you and I, as students and faculty, we will have a tendency to take in a bunch of caffeine because we have late nights. Probably not the best thing for us to do, But again, as that caffeine intake goes up and we couple it over here with stress, now it's going to run into increasing the heart rates up to over 130 beats a minute. Now, with PSVT, it can result in angina. For right now, I just want you to know that angina is a type of chest pain or hypotension, a drop in the patient's blood pressure, and as well as a condition known as congestive heart failure. Congestive heart failure is where we begin to have fluid backing up in the lungs because the heart is beating so fast that it cannot handle the fluid that's coming in. So it begins to back up into the lungs. Now, we'll talk a little bit more as far as your treatment, but understand vagal maneuvers. What I'd like for you to do is just kind of review what vagal maneuvers are in your textbook. We will definitely talk about treatment a little bit later on in the semester, but for right now, we're just focusing in on identification of the different types of rhythms. Now, again, patients with PSVT can be stable or unstable. And when we're talking about unstable, we're talking about if they have an altered mental status, they're maybe not looking right, their color doesn't look good, maybe they're having severe chest pain, blood pressure is dropping down really low, or generalized signs of shock. We'll briefly touch on what you need to do for those patients towards the end of the semester, but we will dig down deep into the treatment of these types of rhythms once you get into advanced cardiology. So this is a breakdown. So basically, now it says 150 to 250 per minute, but for our class, we're going to use anything higher than 130. Now, the rhythm is normally regular except when you see it start and or stop. So you can see along right and through here, it's just tacking along, and then all of a sudden, it suddenly slows down. We get some weird looking beats in here, and we'll talk about those a little bit later on. But this part in here is what would be considered to be irregular. So in this situation, we see it, and then we suddenly see it stop. Now, if we could reverse this, it would be slower, and then all of a sudden it would pick up. So either one of those makes it paroxysmal. A pacemaker site is in the atria. If you are able to see a P wave, it will often be a little bit different looking than when it converts. However, the faster the rate goes, the more difficult it's going to be to see a P wave because, like somebody had said in class on Monday, you're going to typically have it buried in the T wave. Now, if you don't have a P wave, you're not going to be able to measure a PR interval, even if we're working off the assumption that it is within the T wave. But if we do see a P wave, it can be normal or it can be very narrow, okay? Again, depending upon where that pacemaker site is and how close it is to the AV node. Your QRS is going to be normal, okay, as far as a width. So it's not going to be any wider than 0.12 seconds or 3 small boxes. Now, one of the nice things about PSVT is that once you have learned it, you've learned 99% of the next rhythm, which is SVT, supraventricular tachycardia. The causes are the same. It's rarely caused by heart disease. It's most of the time caused by stress or caffeine. You see on there cocaine and nicotine. I can increase it because those are sympathomimetic drugs. The big difference that we're going to be seeing in here is much like PSVT, you can have a reduction in cardiac output because the heart is beating so doggone fast that it doesn't have time to fill up. And as a result of that, the same types of conditions can arise: angina, chest pain, hypotension, low blood pressure, or congestive heart failure. The difference between PSVT and SVT is in the rhythm right here. We neither see it start nor stop, okay? With SVT, again, keep in mind that in this class, it's going to be above 130. It's going to be regular unless we see it start or stop. And in that situation, it's no longer SVT, it's going to be PSVT. Everything else is going to be the same as what we saw with PSVT. If you see a P wave, it'll look a little bit different than the normal P wave that you would see for this patient, but most of the time that P wave is going to be buried in the T wave, especially when you get up to about 140 and higher. If you can see a PR interval, it'll be normal or it will be narrow, but it will often vary. Typically, you'll never see a long PR interval, and your QRS complex will be normal. So again, the only difference that we have between PSVT, paroxysmal supraventricular tachycardia, and SVT, supraventricular tachycardia, is going to be the start and the stop. Now, we talked a little bit about Valsalva or vagal maneuvers. I'm going to skip this slide right here, but I'm going to leave it up for just a second, and you can hit pause and read it. Go back into your textbook and let's do a pre-read on what the treatment is going to be in regards to the simplest way of treating PSVT and SVT. And we'll definitely get into more of that probably around the middle of March or maybe even the 1st of April. Next rhythm we're going to look at is called atrial flutter. Atrial flutter. And basically what is happening with atrial flutter is that you have a site that is discharging really, really fast, again, in the atria, and it is not conducting all of those impulses to the ventricles. Let me go back here and show you. So basically what we have is that we have a site somewhere up here in the atria. Could be in the right atria, could be in the left atria. But it fires, and then the good thing about the AV node is it has a tendency to filter out some of those impulses that get fired. Because again, if every one of those impulses got through, our heart rate would go up and our patient would suffer. So again, we see this quite frequently with patients who have congestive heart failure. We'll definitely get deep into congestive heart failure in advanced cardiology, and if you're taking your EMT class, you will also learn about it in there as well. Now, the big problem with atrial flutter is that it has a tendency to result in really, really rapid heart rates, which basically compromises your cardiac output and reduces it. Again, with these patients, what we're looking at here is we can see that atria that is firing, and then occasionally things get through. Now I'm going to skip this one because, again, it's regarding treatment. Well, let's go to our 5-step method. And so basically what you're looking at here are all of these fence-like impulses that are right along in here, okay? These kind of remind you of picket fence tops. Now, what we don't call these are not P waves. Okay, these are not P waves. These are big F waves or flutter waves. Now you can see that if we, on this one, so let me back up. Let me get my thoughts organized here. So first thing we're going to do is we're going to look at our rate. We're going to look at our ventricular rate. So we'll count 1, 2, 3, 4, 5, 6, 7, 8. Okay, that looks good. So that's our rate of 80. But let's look at our atrial rate. And each one of these impulses that we see here is an impulse that is coming from someplace in the atria trying to cause the entire heart to depolarize. Let's imagine, okay, let's say this is a 6-second strip. And let's imagine, let's count and see what the atrial rate is. So we got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30, 31, 32, 33, 34. Imagine if your heart rate was 340. Trust me, your heart rate would not be 340, but for just a very few seconds. And one of the good things about the way the heart is designed is that it filters out most of those impulses to keep them from coming through. Now, this needs to be treated, and most of the time it's going to be treated by the cardiologist. And so as we're going through here, we have both an atrial rate. I think we said the atrial rate was 1, 2, 3, 4, 5, 6, 7, 8, 80. Ventricular rate of 80, atrial rate of 340. Now, in this situation, we look at the rhythm. In this situation, the rhythm looks to be pretty regular because we're having 1, 2, 3, 4 impulse. 1, 2, 3, 4 impulse. And so that is pretty much set so that for every 4 impulses from the atria, we get 1 depolarization from the ventricle. Now, here's the thing to remember. This can vary. So you could potentially have 2 impulses, ventricular depolarization, 5 impulses, ventricular depolarization, 3 impulses, ventricular depolarization. So in this situation, this particular strip, the rhythm is regular. But if we have variable conduction, which basically means that there's not a set number that occurs before one gets through, now it can indeed be irregular. Okay? So under our P waves, we don't have any P waves. Okay? These are picket fence looking like waves, and these are called flutter waves or big F waves. Previews that come in attractions, we're going to have a small F wave here in just a minute as well. Now, one of the things I'm going to tell you, up until probably about the time we get to your finals, is I would definitely want you to be able to identify this as an atrial flutter. But if you can tell me the conduction ratio, then I'll give you a 50% bonus on that particular question. So if you had this question on a quiz and you said, oh, this is atrial fibrillation, you get full credit. But if you can tell me that there is a 1, 2, 3, 4 conduction ratio on this particular rhythm right here, or if we have different conduction ratios, you tell me it's a variable conduction ratio, then I'm going to give you a 50% bonus for that particular question. We don't have a P wave, therefore there is no PR interval, and because it is flowing and following the normal conduction pathway, the QRS is going to be a normal width of 0.12 seconds or less. So that is atrial flutter. As I told you, atrial fibrillation is coming on. Okay? Now, again, this is showing you the normal conduction pathway where we have an impulse that occurs within the sinus node, and it follows all the normal beaten paths. In atrial fibrillation, we have cells that are firing off in the atria simultaneously. The difference between atrial fibrillation and atrial flutter is we only have one cell that is firing at a time. With atrial fibrillation, we've got cells all over both the left and the right atria that are firing. And because they're firing so quickly and they're all firing at the same time, these waves are going to be much, much smaller. Or, this is important, you may not even see any wave. Okay, now there's going to be some critical criteria here that will help you to be able to identify this. You've probably seen a lot of advertisements on television for atrial fibrillation, for medications, for procedures, and everything, but atrial fibrillation is a real problem for patients. It's not uncommon in patients over the age of 50. And the big issue that we have here is that atrial fibrillation can reduce our cardiac output by as much as 25%. And that is going to be a problem for your patients, okay? We'll talk more about how you can treat it, but for the most part, this gets treated in the hospital. Basically, it results in a rapid heart rate that reduces their blood pressure, hypotension, angina, chest pain. It can result in our patient having an infarction in the heart or dead tissue, as well as congestive heart failure that we talked about. Don't worry as far as about treatment. I'm not going to talk anything about treatment as of yet. Let's look at the identification process. The atrial rate is going to be so fast you can't count it. Okay, as you can see in here, look at these little squiggly lines that are coming along in through here. And so you can tell we have a bunch of them that occurs before a ventricular depolarization occurs. And this one, you don't have as many. This one, you have even fewer. And then this one goes back to a few more. So one of the things that we're going to be looking at here is you're going to see either a very, very chaotic baseline, or you may even see a perfectly smooth baseline. Hold on to that, because I'm going to give you something else that will help you to identify atrial fibrillation as opposed to some other type of rhythm. Now, the rhythm, it says it's irregularly irregular. There is no pattern to this rhythm. What I like to say is that the pattern is grossly irregular. I mean, you can look at this and you don't have to be an expert in seeing that the R-to-R intervals are all over the place. So that's what I call for a grossly irregular. So one of the things I want you to do, okay, everybody listen to me now. One of the things I want you to do is anytime you see this chaotic baseline or you see a perfectly smooth baseline, but your QRS complexes are grossly irregular, the first thing I want you to examine for is atrial fibrillation. Atrial fibrillation. Again, the pacemaker side is coming from somewhere in the atria, and we've got hundreds, if not thousands, of cells that are all depolarizing at the exact same time. These are called fibrillation waves, little f waves, as opposed to flutter waves that we saw in atrial flutter or big F waves. We do not have a PR interval because we don't have a P wave in here. Now, one of the good things about this is that once it gets to the AV node, then it follows the rest of the category or the rest of the route of the conduction system. So your QRS complex is going to be narrow, less than or equal to 0.12 seconds. But the key thing in here is a chaotic baseline or a perfectly smooth baseline, but your QRS complexes are all over the place. Here's an example of another type of atrial fibrillation. You can see that the baseline is very, very chaotic, all right? And then if you measure your R-to-R intervals here, you can see that they are all over the place. So this would be your atrial fibrillation. Now take a close look at this next one. Here's what I was telling you about as far as the baseline being pretty calm. You can see in here, there's a little bit of squiggle on the baseline. You see a little bit more in here. It calms down over in here, but you have no identifiable P waves. But the next key thing you're going to do is you look at your R-to-R interval, and it is literally all over the place. And so that's the first thing I want you to do. It's not always going to be atrial fibrillation. It's got to fit that criteria that we just talked about in the previous, or the 2 slides ago. But again, if you have no identifiable P waves and you've got a grossly irregular rhythm, meaning that your R-to-R intervals are just madly crazy, now that's going to lead you to think, I need to look for this to be closer to atrial fibrillation. Here's another one, okay? This one we see got a little bit of a wiggle in there. Here we've got one that might be a P wave. We're not entirely sure, but we can't say it for conclusively. But the thing that we're going to be looking at in here is this one and this one. No identifiable P waves. It's fairly calm right over in here. But look at your QRS complexes. There's no rhythm to them whatsoever. And so again, I'm repeating myself, but this is important. No identifiable P wave. Therefore, and you have a grossly irregular rhythm, okay? R-to-R intervals are all over the place. It's usually going to be atrial fibrillation. All right, so that concludes our lecture for the second half. If you have any questions, you have any challenges with atrial rhythms, please email me. I look at my email all over the weekend. I'll be happy to to chat with you by email, or maybe I can shoot you a short video, depending on what your question is. When we come back, we will continue with our schedule as it is. Dig into your textbook. I like the textbook because there's so many EKGs for you to look at. And then also work on that quiz. And if you have questions or problems with the quiz, don't hesitate to reach out and let me know. Thanks, guys.